specifically scabies. So just quickly we might throw in a bit of extra stuff into what is scabies. This is from Murtaugh's Patient Education. So it's a tiny little mite, Sarcoptes scabii. It's a type of arthropod and it burrows into the skin, beneath the skin, lays eggs, then dies. The eggs hatch into tiny mites which spread out over the skin and live for about 30 days, and the mites cause an allergic rash. It's spread through personal contact and sexual contact, and the whole family can get it, particularly if you've got overcrowding. Usually get on the hands and wrists. Other common areas are genitals, buttocks, elbows, armpits, waistline, nipples in females, feet, and ankles. So in terms of scabies, the PCCM recommends inspecting all skin surfaces in patients with marked itchiness, looking for scabetic lesions. You want to simultaneously treat all the family members, provide a second treatment 1 week after the first treatment to kill the eggs. If you have severe crusted scabies, sometimes called Norwegian scabies, this requires very intensive treatment, and you should notify all cases of this to the local public health unit. For background, scabies is caused by a mite that burrows into the skin. An allergic reaction to the presence of the mite is responsible for the signs and symptoms. It's usually spread by skin-to-skin contact, although clothing and bedding can be a source. The mite can live away from the skin for 1 or 2 days, or if near a host, or in bed linen up to 4 days. The family tends to be infected. You can get a lot of secondary bacterial infection. In dog scabies is a different species to human scabies. It's very unlikely that dogs play any significant role in maintaining scabies transmission in humans. In terms of presentation, it may present with nothing, marked itchiness, excoriations, eczema and bacterial infection, and scabetic lesions are usually small raised itchy nodules that are typically found in the softer hairless skin areas. Burrows are diagnostic of scabies but often difficult to find. They're short and superficial and have a small distal vesicle overlying the site of the female mite. Crusted or Norwegian scabies occurs when literally thousands of mites are present, rather than the usual 30 to 50. It's not a different species. It's usually associated with immunocompromised, mentally or physically incapacitated people, and is highly contagious, and the itchiness may be unexpectedly mild. For clinical assessment, you want to get a complete history, do your normal OBS, noting in particular BP, weight, and urinalysis. Look at the skin, look for any signs of secondary infection such as impetigo. In recurrent or chronic cases in children, the secondary bacterial infection, check the following, as secondary bacterial infection can lead to acute post-strep glomerular nephritis. So you want to check weight, BP, urinalysis as a baseline, and consider skin scraping for fungal elements or for scabies. In terms of management, if the BP or urinalysis is abnormal, consult your MO. Otherwise, if it's severe crusted scabies, if it's an infant less than 6 months of age, or secondary dermatitis develops requiring treatment. Treat any secondary bacterial infections at the same time, such as impetigo. For open lesions, you can apply permethrin 5%, and permethrin 5% is the treatment of choice. Although it's not approved for children less than 6 months old, it must be balanced against the high morbidity of untreated scabies. And if Norwegian scabies is present, oral ivermectin is recommended. So in terms of approved medication, permethrin 5%, also called Lyclear, can be applied. For an adult and child, you can give up to 1 tube. In a single application, 30 grams. And then percentages of that for younger children. For 1-year-old, 1/8 of a tube. You want to apply it stat and then wash off after 8 to 24 hours and repeat that treatment in 7 days. Simultaneous treatment of all family members is crucial, otherwise reinfestation is inevitable, and you need to check all skin surfaces and cover them all. Avoid the vicinity of the mouth where the cream may be licked off and close to the eyes. you to clip fingernails if necessary, as mites can escape treatment under fingernails. Women should include breasts in application. Permethrin 5% should be left on for at least 8 hours, but no longer than 24 hours. For convenience, it could be applied in the evening, left on overnight and washed off in the morning. Repeat the treatment with permethrin 5% in 7 days. Inadequate coverage is a frequent cause of treatment failure. Fully supervised treatment of patients and contacts increases the likelihood of cure. Clothes and bedding used in 48 hours prior to treatment should be washed in hot water, heated in the hot cycle of a dryer for 10 minutes, or aired in direct sunlight, or kept in a plastic bag for 48 hours. This should be done prior to washing the permethrin 5% off, as to avoid reinfestation. And again, the secondary irritant dermatitis can be treated with topical steroids. In terms of follow-up, that second treatment in a week is needed. This 1 week interval gives the surviving eggs time to hatch. After topical treatment, consider the other diagnoses: unidentified source of reinfestation or comorbid conditions such as HIV infection. And you may need oral ivermectin. Itchiness after treatment is common and can last up to a month or more, especially if nodular scabies are present. This does not indicate treatment failure.